Hey there, PT and PTAs. Welcome back to Studying with Stephanie. Today we are going to continue on our OCS exam prep series, and we are going to talk about examination as a physical therapist. So, as physical therapists, we know that what we learned in school when it comes to examination, the step-by-step process, isn't always feasible in the PT clinic. There are times where we may not get certain measures. There are times where patients can't get into the position to properly measure a muscle by the book, but the whole point of a clinical examination is to piece together your findings. So whatever you get positive on an exam, you're not going to take that for this test means that they have this diagnosis. We're going to piece together everything from the full examination to get this patient the best treatment possible and the best outcomes. So let's get into it. When it comes to examination, what you want to include in every single examination is a thorough subjective history, observation and screening of red flags, objective tests and measures like goniometry, MMTs, special tests. You want to look at functional outcome measures, so whether this is subjective or whether this is something that like a timed up and go score, something that is more objective. We want to try and palpate the area to find maybe the source of the tissue that is irritable. As well, we want to take a look at diagnostic imaging if it's present. Like I said, the whole point of the examination is to piece together the puzzle of what the patient is presenting with. We're going to use the subjective history as a guide. So we want that subjective history to be very thorough. We want to ask questions that maybe the patient isn't feeding us directly. So we're not just testing things to test things. We want to make sure our exam is concise but precise. So we're going to use, like I said, all of those exam findings and piece it together, piece this puzzle together so that our patients can then get the best treatment based on the examination findings. So let's talk about the subjective history a little bit more in depth. When it comes to the subjective history, we want to look at this patient as an individual. So we're looking at their age, their past medical history. Are there strokes? Do they have diabetes? Anything that's going to delay healing? Have they had this injury before? We want to look at what was the mechanism of injury, or how did this patient get injured? Was it a car accident? Did they trip and fall? Did nothing happen and they just started having pain? All of that matters. From there, we want to go into the actual presentation. Is this chronic? So is this long-standing? Is this acute? Is it something that just came about in the last month or so? And then we want to ask about the pain patterns. So what is the pain doing? Does the pain come on in the morning? How does it go on throughout the day? Is it constant? Is it intermittent? Is it just random and sporadic and there's nothing that they can contribute it to? Are there certain movements that you can contribute the pain to? What are the behaviors that are associated with this pain? And how is it affecting your day-to-day? So when we talk about how it's affecting the day-to-day, we want to know how the pain is affecting their function. Is it severely debilitating them where they can't leave their house? Is it affecting their work? Is it affecting their recreational activities? What is this pain doing that's making their lifestyle limited, where they are seeking the care from you? That's also going to guide us to how severe this pain is. Of course, we want to ask that patient on a scale from 0 to 10 so that we can objectify this subjective measure. But we do know as clinicians that everyone has different pain thresholds. We know with things like chronic pain, that pain threshold is going to be lowered. So we want to give them a guideline. And what I've learned over the years is to say 0 is no pain at all, there's no problem. And 10 out of 10 pain is like you need to go to the hospital or dialing 911 because you need emergency medical treatment right at this moment. That helps to create a little bit more of an objective link to the pain rather than that subjective measure. And again, how does that pain differ throughout the day in severity? Is it worse at night? Is it worse in the morning? Those types of things. As well, when we're talking about the pain, we don't want to fixate on it, but we need to know more, again, in order to properly treat this patient. So we need to know that type of pain that this patient is experiencing. Is it achy? Is it throbbing? Is it shooting pain? Is it sharp and stabbing? All of those things are going to help you define what could be the potential tissue that is injured or involved. We know shooting pains, numbness, tingling, those are more of neurological symptoms. We know achiness, tightness, stiffness are going to be more either joint or musculoskeletal in nature. So it's going to help guide, again, what is our hypothesis? What do we think is the injury here or the tissue that is at fault for this patient's symptoms? We need to emphasize as physical therapists that it's important for us to know the patient's daily activities and their occupation. There have been so many times where I've asked a patient, well, what do you do for work? And they say, I just do desk work. That gives me some indication of maybe their potential postures throughout the day, but I need to know a little bit more. I need to know how often are they at their desk? Are they in meetings more so? Do they use a phone at their ear or are they using a headset? all of those types of things. Because if they're presenting with neck pain and their ergonomics are all off, no matter what I do in treatment, it's going to be offset during their 8-hour work shift. Are they taking breaks? Are they walking around throughout the day? All of those are important. Are they going and playing pickleball 3 times a week? As much as patients don't find that necessarily useful for your subjective examination, as a therapist, you do want to dive into those tasks and those day-to-day activities. So I typically like to ask patients, tell me what you do on a day-to-day basis. What activities do you do? How long is your drive to work? All of that matters. And then going off of that, what are your limitations throughout your day? So if you say, oh yeah, I usually drive to work, it takes about an hour, and now I can't drive the whole way. I have to stop halfway and walk around. Or, I work at a daycare and I can't crouch down to get eye level with the students. So all of those things, again, what are their current limitations and what are their functional limitations? Are they having problems with reaching? Are they having problems with lifting? Do they have issues getting their groceries out of the back seat? Do they just have a child and getting that child in and out of the car seat is a little bit troubling for them? How do their symptoms affect their day-to-day life? It matters. And then we also, of course, want to include the patient's goals. Every patient has a goal. That's why they're seeking care. They either want to reduce the pain, they want to get back to their sport, they want to be able to pick up their baby without having pain. They want to be able to return to their day-to-day activities. No matter what it is, including the patient's goal is so important when it comes to our examination, because again, this is going to guide our treatment. If this patient just wants to reduce pain and they don't really have high functionality throughout their day, well, we may focus on more isolated activities versus someone who's a soccer player and needs to return back to their collegiate level of athletics in 2-3 months when season comes back. We need to challenge those patients differently than someone who, again, is coming for just pain. So again, it matters on what the patient's goals are. It's going to help them feel more in tune, feel more comfortable with you as a therapist, that you are truly caring about what matters to them. So after this objective is complete and we feel like we have a good story and we can set the stage for what can potentially be going on with this patient, we're creating that hypothesis. We're figuring out, okay, is this a rotator cuff tear or is it more of a labral issue? Then we're going to use that hypothesis to dive into our examination objectively. So we're going to do things, like I said, goniometer, MMT, special test, taking a look at their outcome measures, and we're going to piece all of those together. And I want to make sure that when I'm creating a hypothesis, I'm not just creating one hypothesis. I'm also creating differential diagnoses for things that I can potentially rule out. And that's when those red flags are going to come into play, so that I know, can I treat this patient or do I need to refer them out? When we are doing our objective measures, it is so important not just to take the measurement down and say, all right, they got 120 degrees of shoulder flexion range of motion with 4 out of 5 MMT. I want to know, what's the quality of their motion? Do they have pain through the motion? Is there a painful arc? Are they having pain at end range? Do they have a tough time sustaining the end range of motion? Can I take them further passively than actively? All of that is going to give a more well-rounded idea of, again, what the tissue is, what the diagnosis can be, and how we're going to treat it. If we know someone has high irritability because they're testing painful through all of the tests, things that maybe shouldn't be painful, then we know we need to take it a little bit easier and progress slower with a patient like this, versus someone who doesn't have any pain throughout the whole exam and doesn't get irritable throughout the examination. It's going to change our treatment plan. And again, this is the whole basis of our exam. We want to get the hypothesis, do the observation, do the red flag screening, take the measurements, determine how the quality of motion is, the functionality, the patient's response to the motions and the test, and then create that full treatment, that individualized treatment plan. And this is why I tell patients that Dr. Google isn't going to do it for you specifically. It cannot get there to look at how your movement pattern is. Sure, you can type in rotator cuff injury and there's going to be millions of different exercises that you can find online. But are you doing the exercise correctly? You may do the exercises, but again, your ergonomics are off and you're reaching improperly. Your scapulohumeral rhythm isn't intact. All of those things are where we come in as specialized clinicians, people who go beyond the measurement to take the full picture of this individual and create their program to reach their goals. That's the whole point of all of this. When we talk about manual muscle testing, we want to do isolated muscle tests versus a whole neurological muscle group. All of that is going to be different. We want to look at their functional muscle strength. Can they squat? Again, can they hold positions? How's the endurance of their muscles? They might have 4+ out of 5 strength with shoulder abduction, but can they sustain that? Can they reach to the side and grab their purse from the top of the shelf? Again, function matters so much to the day-to-day activities. And then of course, as a physical therapist, you want to look at flexibility of not just the muscle, but the nerves. You want to look at the ligament laxity if there is any present. You want to take a look at all those special tests that can help guide your treatment and exam. And this is where clinical prediction rules come in so handy for us as therapists and as medical professionals. Clinical prediction rules are clusters of different exam findings, whether they be positive or negative, that help us create a diagnosis or to progress through a certain treatment plan. So we know there are clusters for lumbar radiculopathy for determining if lumbar traction will have a positive effect, determining if prone instability testing is going to be effective for diagnosing a lumbar instability issue. So all of these clinical prediction rules are going to help us so that we can go into those clinical practice guidelines and treat this patient evidence-based practice. Again, as clinicians, we know that evidence-based practice is what we want to practice, how we want to treat our patients. But again, we're there because we need to find those minuscule, those minute changes that will really go a long way when it comes to patient care. A lot of the times it could be something so simple as just retraining posture, and that helps the patient throughout their whole day-to-day. And they've been suffering with this issue for 4 or 5 months and they never knew that they were walking wrong or that they were sitting at their desk wrong. So as a specialized therapist, please, please, please go into your exam with an open mind and an inquisitive mind. Ask questions, be that detective, figure out what your hypothesis is, track that, try and rule out things that may be presenting similarly, and really give your patients the best care you can by doing these exam processes. All right, so that is examination for the OCS exam. In the upcoming videos, we're going to go over some of those clinical prediction rules. We're going to go over some clinical prediction guidelines. We're going to look at special tests, talk about validity, talk about the specificity and sensitivity and all of that goes into these exams. All right, thank you so much for coming to Studying with Stephanie, and I hope you have a great day. Bye.